Started. It's nice to see all the names in the corner, and I'm happy to be here presenting. And so what I decided to talk about today was a case of an ESRD patient, and just to kind of go through a case and maybe hopefully you'll leave here with a few pearls. This is probably a pretty standard case of a patient with end-stage renal disease being admitted to the hospital. And so we've got a 66-year-old Black male veteran with a past medical history of diabetes, hypertension, HFrEF with an EF of 40%, which is due to ischemic disease, status post-CABG. And he also has ESRD, and he's admitted with shortness of breath. On exam, the blood pressure is 150/59, heart rate of 72. He's 89% on room air, and that goes up to 94% with just 2 liters. Lungs sound a little crackly. He's afebrile. You have a hard time telling what the JVD is doing, but he does have a little bit of lower extremity edema, and overall looks non-toxic. And the labs and data that you have right now coming from his admission is a creatinine of 6.5, a BUN of 45, sodium of 129, potassium of 5, bicarb of 32, phos of 4.5, white count is pretty much normal, hemoglobin is 10.3, which is normal for an ESRD patient, glucose is 180, chest x-ray has some edema. And the outpatient medicines include metoprolol, amlodipine, insulin, gabapentin, and sevelamer. And so the pearls that I wanted to get from this case, so I wanted you to learn a few background information about ESRD and ESRD patients. And a couple of things I'd like you to know and document about your ESRD patients in the past medical history. And some things I'd like you to know and document about your ESRD in patients related to the history of present illness. We'll talk a little bit about the pathophysiology of hyponatremia, since that is one of my favorite things to talk about. We'll talk a little bit about the pathophysiology of HFrEF from the nephrologist's point of view. And then we'll talk about an evidence-based approach to HFrEF and ESRD. And so this is some background information about ESRD patients in general. And I think it's just important for everyone to know this information. This comes from the 2019 USRDS report. And so the US has the highest incidence of ESRD in the world. And the prevalence of ESRD is almost 250,000 patients, 746,000 in 2017. As an expenditure regarding Medicare spending, CKD plus ESRD patients was greater than 120 billion in 2017. That breaks down to 84 billion for CKD and nearly 36 billion for ESRD patients. And that's 7.2% of the overall Medicare budget. 75,000 patients are on the transplant list, so you see that's only about 10% of all of ESRD. CKD is very common. It's about 15% of Medicare patients. And these are interesting highlights that they reported from the database. Basically, 43% of patients with diabetes and hypertension had urine albumin testing. We'll get to why that's important. A third of incident ESRD patients had little or no nephrology care prior. And 80% of ESRD patients initiated hemodialysis with a catheter. So what the highlights of this report are saying is that we have a lot of patients on ESRD that have ESRD. It's costly, and maybe we're not doing enough to take good care of these patients. Just to kind of highlight one other thing, the 7.2% of overall Medicare budget. The purpose of this slide here is to show you that this part right here, this is from the Kaiser Family Foundation, about 1% of Medicare enrollees have ESRD, yet they're 7% of the cost. And so I want to talk a little bit about the mortality rate of patients with ESRD. And it's really quite shocking. So a lot of these epi data is per 1,000 person years. So this top line here is end-stage renal disease patients by modality and their mortality per 1,000 person years. And so you can see our patient here on hemodialysis, his mortality, just being an ESRD patient, is around 170 some per 1,000 patient year. Yet if he had a transplant, this would be what his mortality rate is, and this is over time. And the other thing that this slide shows you is that we are not making a ton of progress on mortality in ESRD. And so one thing to realize is that the mortality rate is highest within the first year after starting hemodialysis. And then the median survival of a patient who initiates hemodialysis, this top line right here, this is hemodialysis patient mortality. This is 2013. So median survival is 3.9 years. And the 5-year survival is 40%. So it begs the question, oh yeah. And so these are actually really stunning statistics. So expected remaining years of life is lower in patients with ESRD requiring dialysis in all age groups. So if you take, let's just take a 45-year-old man on dialysis, he can expect to live 9 more years. But if he had a transplant, he can expect to live 24 more years. And just compared to the general population, he can expect to live 32 more years. And this is for all age groups from age 40 to over 85. And so mortality in ESRD on dialysis is higher than cancer, diabetes, heart failure, stroke, and acute myocardial infarction. All diseases, I think we'd all agree, were important. But the rate of mortality, for example, dialysis on ESRD, 257 versus 67 for cancer, 37 for diabetes, heart failure, all these statistics. And it really kind of comes to home when we show this original graph with our dialysis patient up here at the top compared to all these other significant diseases. And you can see that a patient with a transplant kind of blends in with these other more serious diseases with a reasonable expected mortality rate. So what's our patient's mortality? And again, this is dependent on his age and the years on hemodialysis. Luckily, our intern knew the answer to this question, and I think this is relevant to include on your H&P. And so he knows that this patient has been on hemodialysis for 3.9 years. So he's reached median survival. So what are our patients dying of? And so this is also from the USRDS database. And you can see here, all of this section here is cardiac stuff. So heart failure, heart attack, arrhythmias, cardiac arrest is the majority of cause of patient death in our ESRD patients. And the second leading cause is infection. So that begs the question, given that cardiovascular disease is the leading cause of mortality in our patients, what is the #1 intervention that improves mortality for ESRD on hemodialysis? If anyone feels like unmuting and shouting out an answer, feel free. If you just want to stay on mute and shout out an answer in your house, that's okay too, but maybe think about what the right answer is here. Well, I already showed you these data. It's obviously transplant. And so is our patient a candidate? And this is also, I think, very relevant to include on your H&Ps. And I guess part of the take-home message I want from this talk to be is for you to be transplant advocates in your patients and at least discuss it, since this is the thing that dramatically affects mortality. So since we didn't ask that question, our young intern is running back to the patient and going to ask him that question. And unfortunately, no one has asked this patient if he is interested in transplant and not provided him with information. And that's not an uncommon scenario, unfortunately. And so these are our first set of pearls. Number one intervention to improve mortality in ESRD is transplant. Leading causes of death are cardiovascular disease and sepsis. Median survival is 3.9 years. Please include time on hemodialysis and whether your patient is a transplant candidate in your H&Ps. And you may have noticed, so 40% survival at 4 years or at 5 years, and 40% of the cause of death is cardiovascular disease. And so then you document this in your history and you go back and you say, hey, doc, and your patient says, hey, doc, am I a transplant candidate? And it's okay. I don't know the answer either, and we're going to go over this quickly. So transplant candidacy 101, just refer as many patients as possible. It's an equitable approach, and it's a good conversation to have about why they are not or how they could be is valuable. But the things to think about so that when you ask your patients about this, that you can have a general conversation with them about. So the general contraindications and factors for consideration include whether or not they have active or uncontrolled or irreversible disease, factors that might affect immunosuppression adherence, factors that affect safety of immunosuppression, factors that affect short-term survival, and factors that may affect success of the surgery. And so these are the specific contraindications and considerations that are directly copied and pasted from the university guidelines. So basically, significant cardiovascular and pulmonary disease. And I asked a couple folks about what EF constituted significant cardiovascular disease. One answer I got was an EF less than 40%, and another answer I got was an EF less than 30%. And then for significant pulmonary disease, it's oxygen requiring. So other things are AIDS, uncontrolled HIV, chronic infection, untreated Hep B, active malignancy, mental illness, evidence of non-compliance, ongoing substance abuse that does include tobacco use in patients with other cardiovascular risk factors, and morbid obesity is evidenced by a BMI greater than 42. So the relative exclusion criteria are lack of social support, lack of financial support, lack of transportation, and end-stage liver disease. So we know the best treatment for ESRD is transplant. What about prevention? And so let's think about what the two major causes of ESRD are. And I'm sure you already know this, but this is showing these data in a different sort of way. So as you know, diabetes here and hypertension are the leading causes of end-stage renal disease. And the way this is listed here is that it's the number of patients who have that as their primary cause. And so the causes here are diabetes, hypertension, glomerulonephropathies, cystic disease like polycystic kidney disease, urologic, and other unknown. This is the total number of patients, and then it's by essentially renal replacement therapy modality. And so in blue here is hemodialysis, home hemo, peritoneal dialysis in gray, and then transplant in green. And so it's interesting to me that fewer of patients with diabetes or hypertension are getting transplanted versus some of these other causes. And so sometimes internal medicine feels unsatisfactory. You know, you've got somebody in your clinic and you're trying to tell them, if I treat your blood pressure with medicines that you might have side effects from, even though you don't have side effects from your blood pressure, is this going to do any good? And the same thing with diabetes. And I just want you guys to get really excited about treating your patients with diabetes and hypertension, because so many of these people may end up on dialysis, which is not the outcome that you want. And this is another slide showing some health disparities. We have so much work to improve in this area with access to transplant in Black patients is so much lower than it should be. And this is another place that we can start being advocates for our patients and having that conversation at the bedside. So let's fill in our ESRD past medical history. So the things I'd really like you always to include in your past medical history of ESRD patients is time, transplant, and then etiology. And just to remind you, when you see those patients, to sort of think, wow, what could have been done different for that patient, and what can I do different for my patients in the future? Okay, so the next thing, going back to our patient, so we've got this patient here, and he's got shortness of breath, and there could be a zillion different causes of that. So how are we going to fit that in, and what are the relevant questions in an ESRD patient related to the history of present illness? And so these are all pretty obvious, but somehow we don't always see those in those notes. And so the number one question in your ESRD history of present illness is, sir, what is your dry weight? And they will almost always know what their dry weight is. So you don't have to worry about contacting the dialysis unit or any other fancy pants try to thing. You won't find it in the record, but if they're awake, they'll know their dry weight because they've probably argued about it at some point with their staff. The next thing is, when was your last dialysis treatment? Missed any treatments? Any issues getting to dry weight, and any trouble with access? And you want to know this because you want to try. The trouble with the access getting to dry weight is the patient hypotensive, having other issues, and if they're hypotensive during dialysis, that suggests that there could be new cardiovascular issues. But mainly we're trying to figure out, is this simple shortness of breath in an ESRD patient or not? So we got to run back and ask the patient a few more questions. And what we find out is that his dry weight is 67.5 kilograms. Last dialysis was Saturday. Usual is Tuesday, Thursday, Saturday. Today's Tuesday in this H&P. He's not missed any dialysis sessions, and his access is working great. No troubles getting to dry weight. So now we're kind of wondering, is this really a fluid overload problem? But our hero intern weighed the patient to fill in the physical exam, and as a standing weight, got 74.5 kilograms. So he's 7 kilograms over, i.e. 15.4 pounds over his dry weight. So we're starting to think that this is probably just related to volume overload. But one of the things I always like to say is that, the presence of one thing doesn't rule out the presence of another thing. So we always have to consider, is this volume overload plus worsened heart failure? Or is this volume overload plus worsened heart failure plus minus something else? And so we're not going to get into exam or anything like that. We're going to get into hyponatremia, which is one of my favorite things to talk about. If you remember from the initial H&P, this patient was hyponatremic with a serum sodium of 129. And so the question is, does this help us think about having worsened heart failure? So there's two questions, and I want you to think about what the right answer is. So which of these statements is true? Number one, this is hypervolemic hyponatremia, and thus supports the possibility of worsened heart failure, fluid overload, and edema. Or is the second statement true? This patient is hypervolemic, and the patient has hyponatremia, but this does not give any insight into whether there is worsened heart failure or not. Any votes? I can't see anyone. Any votes for number one? Votes for number two? Okay. So the correct answer is two. And so I think it's important to go through this pathophysiology because I've seen this hypervolemic hyponatremia written in our patients with end-stage renal disease. So this is one of my favorite things to talk about. So let's go over just briefly the pathophysiology of volume regulation and edema in heart failure without end-stage renal disease. So before you have heart failure, you have normal volume status and you're happy. And then you have low cardiac output for whatever reason. And remember, this triggers the release of the volume regulatory hormones, renin, angiotensin II, aldosterone, and sympathetic activity, which results in sodium retention, mainly as a function of aldosterone acting at the distal tubule. This results in increased plasma hydrostatic pressure and peripheral edema. And this cycle continues while you still have low cardiac output. And this results in a urine sodium, which is in a low urine sodium, which is pretty much the hallmark of poor perfusion and activation of the renin, angiotensin, aldosterone system. So we've got this going on in our heart failure patients. So how do these people get hyponatremic? Oh yeah, one other thing is, so if you remember this pathophysiology, you remember all the treatment for heart failure, right? So we've got all these things active resulting in edema. And so this is how we treat patients with heart failure, with diuretics, ACE inhibitors, spironolactone, and beta blockers to inhibit sympathetic activity, aldosterone, and the renin angiotensin II aldosterone system. And remember, this is in patients without end-stage renal disease. So now we're going to talk about the pathophysiology of volume regulation and hyponatremia. So your first defense to maintain volume status in low effective circulating volume states is the renin angiotensin II aldosterone system. However, if your body becomes really desperate, you will also release ADH. And I like to think of ADH as sort of this key that unlocks the tubules here and allows for the resorption of water. And that leads to a concentrated urine. And that resorption of water helps to maintain volume status. But to resorb water, you have to be drinking water. And so what happens, and the reason you get hyponatremic in heart failure is the action of ADH plus drinking water. And it's well known in the regular population without ESRD that hyponatremia is a fairly poor prognostic factor and shows really poor effective circulating volume. So what about the pathophysiology of hyponatremia and ESRD? Well, that's actually quite a bit simpler. Basically, you have no kidneys, so there really is no activation of ADH that matters. There's no activation of anything else that's active. It's really from drinking water, and it's as simple as that. So this does not help us decide if this patient has worse heart failure or not. So what did we learn here? Pathophysiology of edema and heart failure is simply renin angiotensin II aldosterone, leading to a low urine sodium and edema. Pathophysiology of hyponatremia is related to ADH and water drinking. The pathophysiology of hyponatremia and ESRD is simply drinking water. So meanwhile, our patient has been put back on dialysis. He says that he indulged a bit over the weekend, including several beers during the Bronco game due to watching a wide receiver play quarterback. He's had 6 liters of fluid removed. He's not hypoxic anymore. He feels well, and he's wondering, can I go home? And so the last thing we're going to talk about is what evidence-based treatment changes can we make to optimize HFrEF treatment in this patient. So I want you to check all that apply. So change metoprolol to carvedilol, add an ACE inhibitor, add an ARB, or add spironolactone. And so if this were not an ESRD patient, you might consider doing any one of these things. But the only thing that's been studied in ESRD patients is carvedilol, and that would be the one evidence-based treatment approach that you could do. And so the thing to also know is that end-stage renal disease patients are generally excluded from clinical trials of cardiovascular disease. and clinical trials in general. And the reason for this is they generally don't behave the same way as the general population. And so we cannot assume that what applies to the general population holds true for ESRD patients. So by comparison of the other goal-directed therapies, carvedilol is reasonably well studied in HFrEF and ESRD, and there actually is a randomized controlled trial showing better outcomes. And there's a meta-analysis also showing better outcomes. And it's the only drug of the HFrEF bunch that's shown a survival benefit in patients with ESRD. Believe it or not, ACEs and ARBs have not been studied in a randomized controlled trial in ESRD patients, and may, however, be useful adjuncts. But you do need to monitor for hyperkalemia. And spironolactone is controversial. There was a time where there was one study that showed a benefit, and now there are studies showing harms, and probably needs more study. So this is our randomized controlled trial. And this was done in Italy. So I think that's interesting. We keep track of all of our end-stage renal disease patients in the US, and the only randomized trial of HFrEF therapy was performed in ESRD was performed in Italy. But what they did is they had 114 dialysis patients with cardiomyopathy, and they were randomized to carvedilol or placebo and followed for 2 years. Their results are actually pretty impressive. I almost wonder if they're too impressive. The mortality at 2 years in the placebo group was 73%, but we know that our end-stage renal disease patients have high mortality versus 51%. Cardiovascular death was 67.9% versus 29%. Hospital admissions was 58.9% versus 34.5%. Confirming or at least supporting those data is this really nice study from Taiwan. And Taiwan actually has a lot of great nephrology studies, both in AKI and ESRD. They have a huge registry of all their patients, and have done a flurry of propensity analyses for various outcomes in ESRD and AKI. And so this is a fairly impressive study. Even though it's retrospective, taking the patients from their database of ESRD and heart failure, it's a 10-year study, and they selected 1,700 new users of beta blockers. And now this is all beta blockers, or 3 different beta blockers. It's metoprolol, carvedilol, and bisoprolol, versus 1,700 non-users, and matched according to propensity scores, and then looked at 5-year all-cause mortality. And so their data show that beta blocker in the control group, in the study group that got a beta blocker was 54%, and it was up to 70% in the non-beta blocker receiving group, which is kind of similar for the randomized controlled trial, lending plausibility to that. And then this is an even more recent study that I found in the Iranian Journal of Kidney Diseases from just 2020. And basically, whenever you're trying to find data on something, somebody always has done a systematic review and meta-analysis. And this is carvedilol in particular on cardiovascular events and mortality in hemodialysis patients. Basically, this is figure 2 here, A, B, C, and D. And they have forest plots for all-cause mortality, cardiovascular events, hospitalizations, and improved LV, left ventricular ejection fraction. And so you can see these aren't like the most spectacular data in the world, but they certainly do suggest that for all-cause mortality, cardiovascular events, hospitalizations, and in particular, ejection fraction, all of these studies favor carvedilol for these outcomes. And so this has actually been adopted by societies. This is the KDOQI guideline, which is one of our national groups, and Up to Date, which is what everybody reads. This is guideline 6 from the 2005 National Kidney Foundation recommendations on cardiomyopathy. This is another sort of pearl. So the prevalence of heart disease in our ESRD patients is estimated to be at least 75%. And that was in this study. I found another paper showing about 80%. So again, kind of showing that we really should study these patients a little bit better. But their conclusion was, pending further data, carvedilol should be the preferred beta blocker for the treatment of dialysis patients with dilated cardiomyopathy. And one hypothesis that's come out is that it may provide particular benefit because it's poorly dialyzed versus metoprolol, which is well dialyzed. This is a more recent guideline statement from the KDIGO group, this group and their impressive institutions. And this was just published in 2019. And this shows kind of a summary of evidence for treating patients with ESRD and heart failure. So this kind of category here is the ESRD population, the CKD-G5, and basically showing strong data versus absent data for improved outcomes in patients with heart failure and that category of renal failure. And carvedilol, again, is at the top of the list with strong recommendations. Next is other beta blockers, and then weak evidence for any other treatments, and then potential harm with digoxin, which kind of makes sense. And so the last pearl I'd like to leave you with is think carvedilol in your patients with end-stage renal disease and heart failure. And that's what I've got for you. And I'm happy to take any questions.
Dr. Faubel, that was great. And I apologize. I had to step away in the last 10 minutes of that, so I didn't get to hear all the evidence base for the heart failure treatments. But did you, so is there any recommendation about ACEs and ARBs in these patients? Is it just if they get started on beta blocker and they still have significant reduced EF after being on beta blockade, we should consider if they're ACEs and ARBs for like people who are on scheduled dialysis?
Yeah, so yes, so the only evidence, again, as I sort of said, was for carvedilol. So the up-to-date recommendation and other guideline recommendations do include using ACE or ARB together, together with beta blockers. And then you do have to monitor for hyperkalemia. And so the idea, again, our patients can get really hypotensive on dialysis. So the major consideration is that you kind of have to start low and go slow. And so in the inpatient setting, your best, the thing that you're probably going to change in the inpatient setting is getting your patient on carvedilol, and then when they leave, you would start low and up titrate and perhaps go back and forth. But the only data is truly for carvedilol, which is kind of amazing.
I think UCH residents had a question too about anybody that's admitted with ESRD that has HFrEF, should they be switched from metoprolol to carvedilol if their blood pressure tolerates it, even if they were not admitted for a heart failure exacerbation or anything else?
Yeah, it's a really good question, right? Because it's almost like when we see a patient in our clinic, do we do some of the primary care stuff? So you would think that, this might have been addressed in the outpatient setting or at the outpatient unit. I was pretty struck by these data. So I've been leaning towards switching people, but I haven't vetted this with my nephrology colleagues. So I think it's the right thing to do. But whether you'll be stepping on toes from other dialysis centers, you could potentially talk to your nephrology colleagues or talk to that dialysis unit and see if they would have a problem switching over. But given that there's so little evidence in our patients, and this seems to be the right drug for people to be on, I think that is something that you can do to improve outcomes in the patients. And I think that our ESRD, just one other kind of speech is, our ESRD patients get put on a lot of things that then fall out of favor. I'd say like early on, for like AFib, a lot of patients have been put on apixaban that don't have a high enough risk of stroke, and we're starting to see more bleeding complications, and the data are suggesting that maybe we need to stop some of those medicines. So I think a reevaluation of the meds that ESRD patients are on is appropriate, and that a switch to metoprolol in general should be advocated for. But the best way to do it is probably in consultation with the primary unit.
Dr. Faubel, I had a quick question for you too. I know that earlier you had spoken about hypertension causing ESRD, and I know that there's like this great debate now about whether it actually does or not, or whether it's just a consequence of ESRD. Did you have any like quick thoughts on that?
Yeah, I am not the best person in the world to answer that question. And I know that I would talk to Jessica Kendricks, Stu Linus. What I would say is we know that improving hypertension reduces your chance of progressing with CKD. So whether that's what I would say. And so I would say it's regardless of the sort of nitpicky details, even though that relationship is controversial, if you look at the USRDS database, it's what people have listed as their secondary cause, and certainly contributes to poor outcomes and for our patients with CKD. So I would say I would leave the esoterics for the experts and still treat the hypertension in your patients with CKD.
Got it. Appreciate it.
Yeah, and one other question, I think probably everybody that, all of us who rotate on the inpatient would be really helpful to kind of know about, when we get, you were talking about patients getting hypotensive in dialysis, and one of the common things for on the dialysis days is the units tell them to hold their antihypertensives, and sometimes metoprolol sometimes sneaks in there as well. And I guess my question, I've had patients who have AFib who are on metoprolol and pop into AFib just from missing like one dose of it. And I didn't know, kind of from your perspective, I guess like, especially like on these patients who are getting dialysis or getting hypotensive, I know metoprolol doesn't have that much definitely doesn't have as much effect on blood pressure as carvedilol. Should we just tell the nurses to continue with the metoprolol on those dialysis days?
Yeah, that's a really good question. Yeah, that's one of the ones that we don't always hold. And I have to say, like one of the rules of thumbs of hospitalized patients is they're either going to develop AFib with RVR or altered mental status. And so anything that you can do to avoid having a patient pop into AFib, I think is reasonable. I would say that there's probably advantages to carvedilol to avoiding that situation, since it's not removed by dialysis. And so might give you more sustained control in that regard.
And I guess if they do get hypotensive in dialysis, should we just say let's dose reduce them just so we can rate control them and yeah, be able to keep them on carvedilol for obvious reasons if they have heart failure too.
Yeah. We have all kinds of tricks to try to get people through their dialysis sessions. Well, I think if there aren't any more questions, we can give you 13 minutes back in your day.
Yeah, thank you so much for talking with us today. This was I had some people texting me about they had no idea about carvedilol having a so much more of a benefit than any of the other evidence-based beta blockades that we do for heart failure. So thank you so much. I guess one of the UCH residents had one question. They said,
Sure.
they talked about a resident in the room asked about ESRD and the response to sepsis. And I don't know what the question in per se is about in regards to that. I don't know if they're talking about fluid boluses or what in that regards.
That's okay. I think it's one of the really interesting things to talk about. So, right, sepsis is the leading cause of death in patients with ESRD. The thing to know about how patients with ESRD present with sepsis and how they present with when they're sick, the SIRS criteria are now, I don't know what we're on now. None of those things apply. So your patient can be fully bacteremic and not doing well and be afebrile, not hypotensive and waving at you, hey doc, how are you doing? So because patients with ESRD are generally immunosuppressed, they don't manifest kind of that SIRS response the way other folks do. So it's actually unusual to see an ESRD patient with like full-blown ARDS and florid sepsis. That said, so if they do get sick, you're kind of stuck with limiting fluid boluses. And that's actually another reason people think that they may do better because they don't get as fluid overloaded as the general population. So if you take a ESRD patient who gets sick with sepsis, like their mortality rate in the ICU overall is probably 20 to 25%. Compare that to a patient with AKI requiring dialysis in the ICU, that's around 50%. So even though their mortality is higher, their immune response is so much less that they present in a little more puny way. So you have to have a high index of suspicion a lot of times to evaluate and treat your patients with sepsis. And avoiding fluid you would lean towards pressors before lots of fluid in your ESRD patients. But that said, giving like a 500 cc bolus here and there can be helpful if you need to. And hopefully one of those ravings answered the question that you might have had about it.
It looks like it did. So thank you again so much for talking with us today. This was fantastic. So we really appreciate it. Thank you.
All right. Happy to help. Everyone have a great day.